All right, so I want to transition slightly. We have two products, the third kind of again in clinical trials. Right now, this is pretty intensive care required, not in both in intensive hospitalizations as well as intensive care units, at least with oxycaptogene sialosyl. What's the potential for outpatient administration of these treatments?
Well, I think you probably can speak to that best, but I think that's a goal, especially if you can identify a patient population that may be less bulky, that you would expect to have less cytokine release syndrome and less neurologic toxicity. And I think, and I'll let you speak to it, you have to have a center set up so that you have 24/7 availability of medical personnel, and I think your center at the Hutch is doing that.
I think it goes beyond your center evolves into your ER. Or you have to, if you're going to do outpatient CAR T-cell therapy, they can end up in the emergency room, despite all the best efforts of trying to get them to your respective treatment centers. And so if you're going to do outpatient CARs early on, we're all kind of doing this in broad education at our centers.
Right, now we've actually evolved to do that. I think the Hutch has done that too. We started with only inpatient, and once we got comfortable, we had to put a system in, and everyone was nervous. It was a problem, it was a challenge, but we worked it out. So all our patients are tagged. They have a band on that shows the ER. If they're a CAR T-cell patient, we have a notification process. But once the outpatient team was trained and got good at managing it, we now feel very comfortable starting outpatient, because if they have a problem, they come in immediately.
Yeah, so that's with a 4-1BB CAR. And so,
correct.
Yeah, so I mean, I think the data right now is with the Juliet trial, I think about 25% of those patients were actually treated as an outpatient. And we have actually quite a bit of experience now with the commercial tisagenlecleucel, like Lucil, where we can deliver that as an outpatient, and it functions very similar to our experience with earlier 4-1BB CARs, our JCAR17. When we do that, you admit patients at the first sign of something going wrong. So that's almost always a fever. Yep. And so we've been able to do that, and people get admitted somewhere between day 3 and 7 or not at all. Mm-hmm. And we have about 30% of patients that can stay out of hospital the whole time without having significant issues. With the JCAR17, we have now increasing experience across some of the centers in New York, and I don't know whether you guys have experience with that yet, but we've been able to treat most patients as an outpatient, and again, admit them at the first sign of symptoms, and they usually don't require escalation of care into like an ICU. But I think a lot of this is because it's different products. Yeah. I think the tisagenlecleucel and the lisocabtagene maraleucel are different products than oxycaptogene sialosyl, and that the CD28 versus the 4-1BB makes a big difference. And I have not treated any patients with oxycaptogene out of the hospital, and because most of them get CRS really quickly, and they're in there at least, a couple of weeks.
I totally agree. Right now we're just doing the studies on the CD28s, and we keep them in the house.
Yeah, I think that's a key issue. But at some point, if we have these other products approved, then this will come into play in terms of resource utilization. And I know we'd presented a little bit showing that you can get by with much fewer days in the ICU, much fewer days in the hospital, and you would think that will eventually translate into healthcare utilization costs of delivering this type of treatment.